Hi Caitlin, I'm Ashley. I'm your student physical therapist. I'm going to be working under Dr. Clausen today. And if it's all right with you, I would like to place my hands kind of around your shoulders and your neck and your knees just to palpate a few structures to make sure we know what's going on. Does that sound good?
Mm-hmm.
Perfect. So we'll go ahead and start here in the back. We'll start by finding the spinous process of C2. So we'll just come off the base of the skull and find that first bony landmark that protrudes. That's the spinous process to C2. And that's important because as she flexes forward, we can really feel that nuchal ligament running up and down. And then as well as finding that spinous process, we can go ahead and count down to find the other spinous processes as we work down to find all the bony landmarks there. Which we'll go to next is C7, which is the most prominent of the spinous processes. And then just above it will be C6. And we can check that by having her flex and extend her neck. So when she flexes, C6 will kind of protrude out, and when she extends, it kind of disappears, which it did, while C7 doesn't move at all. And that's important because C7 can also be our landmark to work our way up and down the spine on the other spinous processes, as well as it's a weight-bearing joint right there, so it tends to have a lot of problem with bulging discs and needing of fusions. Next, we'll go ahead and come to the side, just lateral to the spinous processes. We find the articular pillars, so we'll have to just kind of push down deep through the soft tissue and we'll find that bony end feel. And right there we have the running of the paracervical muscles, and then as we go lateral and just kind of wrap around those muscles, we'll find the articular pillars, which have a lot of nerves and arteries running through there, so we have to be careful not to pinch or irritate those nerves. From there, we will just put our hands down onto her upper trap, and we'll be able to palpate the first rib, just pushing down through the soft tissue. We find that bony end feel, which the first rib is important as we have the attachments to the scalene muscles, as well as between the middle and anterior scalene muscles, we have our brachial plexus and our subclavian artery, which we need to know, especially if we're going to be doing some dry needling. So from here, we'll kind of work our way forward. We'll find the clavicle and use our hands to find where the clavicle and acromion meet. Right here we have the joint space, so that's our acromioclavicular joint, which is a common place for separation. You'll see the piano key and be able to tell with your eyes if there's a separation there. And then it's also a good spot to find the coracoid process as we come anterior, as well as the spine of the scapula as we come posterior. And that's where we'll go next, the spine of the scapula, which we can just kind of follow all the way back. And right above it, we have the supraspinatus, and below it, the infraspinatus muscles. And then as we come around, we can find the medial border of the scapula with a bunch of muscle attachments there. And as we work our way down, we find the inferior angle right here, which we can then find the teres major and minor muscles. And then as we have her move her arm, we can see the rotation of the scapula to make sure that the scapula is rotating correctly. So as we come back up to the acromioclavicular joint right up here, we'll just fall off the acromion process and we'll find the soft tissue space right here. This is the subacromial space where we have the supraspinatus coming out and attaching onto the greater tuberosity, which is a common site for shoulder impingement, as well as we have a bursa right here, which gets a lot of bursitis. So from here, we can just fall off anteriorly and use our palm to find the greater tuberosity of the humerus. And so once we found that, we can check it with our finger pads and move around. As we go medially, we fall off into the intratrabecular groove to find the biceps tendon long head. And then we also have the attachments of the rotator cuff muscles all in there, as well as it creates the lateral border for the intratrabecular groove. As we just go medially into it, we can palpate down into the soft tissue. It's usually a little bit tender because there's a lot of soft tissue to poke through, but there's the coracoid process, and that is the attachment site for our coracobrachialis, the short head of the biceps, as well as the pec minor. So from there, we'll come down her arm, and we'll use our palms to find the medial and lateral epicondyles. Medially, we have the epicondyle that is the origin for the forearm flexors, And then if we come in medially in between the biceps tendon and the medial epicondyle in the cubital fossa, we'll find the brachial artery. And then laterally, on the lateral epicondyle, we have the forearm extensors. And as we come in towards the cubital fossa, we'll be able to palpate for the radial nerve. Also on the lateral epicondyle, we just move inferiorly and we can feel the radial head. It's just lateral to the olecranon process, and you can grab it with your fingers and then your thumb on the in the cubital fossa to kind of move it around. This is an important structure because it's a common subluxation in children, and then it also can help us see the shaft of the radius all the way down to the styloid process and then be able to find the radial pulse there. So go ahead and I'll have you extend your hand, and we'll have the anatomical snuff box, which we can palpate down deep into and find the scaphoid bone. That's the bone that is commonly fractured with a fall and outstretched hand and will need to be x-rayed, just to be careful with that one. It's also where we can find the tendons for our extensor pollicis longus and our extensor pollicis brevis and adductor pollicis muscles. So from here, we can have you go ahead and turn your hand in with your thumb, and just off the ulna, we'll find the joint space and then the triquetral bone, which is a good landmark to be able to find the tunnel 5 and 6, which houses the tendons and muscles for the extensor digiti minimi and adductor digiti minimi. And then we can also flip it around to use it to find the pisiform and hamate. So then from there, we'll go ahead and move to the knee. We'll have the patella that we can feel with our palm, and then move on either side of the patellar ligament. As we put our thumbs on either side of the patellar ligament, we'll fall into that joint space, the joint line. Up above, we have the femoral condyles. Down below, we have the tibial plateaus, and so we can palpate the menisci right here, and then as we move to the sides, we'll be able to have the lateral collateral ligament and the medial collateral ligament that we'll be able to palpate. And then we can take our palm and find the fibular head right here, and once we do, we'll be able to find the fibular nerve right behind it, and then we can also find the head and move up to find that lateral collateral ligament. All right, I'll go ahead and have you lay down on your back next, and we'll start with your ankle right here. So first we'll find the medial and lateral malleolus and then work our way into the joint line. Just under the tibia, we'll have the dome of the talus, which we can check by having her bring her toes up and it disappears, and then her heel up and it protrudes out more. So that's the dome of the talus, and then you can grab the neck of the talus, which is an important structure because we have a lot of ligaments that run off and attach there, as well as it's part of the subtalar joint and gives us a lot of inversion and eversion. So one of those ligaments that it's important is the anterior talofibular ligament, which comes from the fibulus to the talus, and we can palpate right in there to find that ligament, and then do inversion to check for the tautness of that ligament. It's the most commonly sprained ligament, and it can also help us orient to find the other ligaments that run off of the fibula onto other bones as well. And then we'll go into the base of the fifth metatarsal, which is just right here. We'll find the styloid process right there, which is the attachment site for fibularis brevis. And then if we fall just behind it, we can find the cuboid tarsal bone. And then on the medial side, we can find the navicular by palpating. That's the next protruding bone from the malleolus. And we can work our way up and use the joint spaces to find the cuneiforms, as well as the attachment site of the navicular for the tibionavicular ligament and spring ligament. All right, from there we'll come and move over here. If it's all right with you, I'm gonna palpate kind of in your abdomen and then also on your hip region. Is that okay? Mm-hmm. Perfect. So I'll come up, find her ribs. Sorry, my hands are cold. And then, where are you? Oh, there it is. And then, so you're laughing. I'll palpate down and have her breathe, and I'll be able to feel the liver pushing up into my hands. And that's important because it helps us kind of understand the quadrants and where things are in the quadrants of the abdomen, as well as if it's tender or has abnormalities, it's something we need to refer out to. And then I'll come to the side and feel her iliac crest, and then kind of move my hands and feel on my palms, I'll feel her anterior ASIS, and then I'll be able to find the sartorius just under there, as well as use it as a landmark to find the TFL and the inguinal ligament. So go ahead and I'll have you extend that leg, put this foot on your ankle, and then if you wouldn't mind grabbing your shorts and pulling them up as high as you can, that would be great. So I'm gonna go ahead and hold this, and I want you to pull your leg in, and then we see the adductor longus popping out right there. And then on this side, we've got the sartorius, and right in between is our femoral triangle, where we'll find the femoral artery, vein, and nerve, as well as the floor of this triangle is the pectineus that we can find. All right, go ahead and extend your legs, and I'll have you roll onto your side. We'll use the palm of our hand to find the greater trochanter, and then we can use our finger pads to kind of poke around and find if there's any tenderness with the bursa and they have a bursitis, or with the attachments of the hip intrinsic muscles, the external rotators down in there. We can also go up to the iliac crest and find the 12th rib, which will be kind of posterior, the last bony landmark, and in between that we have the quadratus lumborum. And then as you rotate onto your stomach, we can find that 12th rib again, right there, and work our way up until we find T12. So I'm going to move into the gluteal region and palpate your hips. Is that all right with you, Caitlin?
Yeah.
Perfect. So we're going to come down here, find the iliac crest, work our way back, and use our palms to find the PSIS. Right there we've got the PSIS, and right in between is S2. It's also a good place to check for pelvic symmetry. So once we get to S2, we can kind of move up and wait till we find the most prominent vertebrae. Right here we've got L5. And then L5 is important because it helps us as a landmark to work our way up the spine and check the other lumbar spinous processes, as well as it's the most common site for low back pain between L4 and 5. And then we'll move down into the sacrum, and we'll go ahead and find the sacrum again, PSIS, S2, and we can work down all the way to the coccygeal joint and the coccyx. And then if we move laterally, we can find the inferior lateral angle, which is right there. And that's important because it is the attachment site for the sacrotuberous ligament, as well as the posterior sacroiliac ligament. And then the last part on our list is the ischial tuberosity, which we'll just find the gluteal fold right here, use our thumb to push up and in, and that will be the ischial tuberosity, which is the attachment site for the origin for the hamstring muscles. As well as if we find that ischial tuberosity, we can also move medially in order to palpate the pelvic floor. And that's it.